Welcome back for another episode of From Pregnant to Parent Presents. If you're new around here, I'm Richelle, the founder of From Pregnant to Parent. I'm a toddler mom, a childbirth educator, doula in training, and I'm based in the Bay Area. I'm here to help guide new and expecting parents through pregnancy, childbirth, and the first year of parenthood. This week, I'm so excited to be chatting with my favorite NICU nurse, my own mom, who's going to just talk to us a little bit more about what you might expect, what exactly is the NICU, just to help kind of eliminate some of the fears of the unknown in case you happen to find yourself there after your new baby arrives. So, Mom, I'll go ahead and pass it over to you to introduce yourself.
Hi, I'm so happy to be able to do this with Richelle. So like Richelle said, I'm Kathy. I have been a NICU nurse for most of my career. I did 1 year of adult nursing and then fell into the NICU on a fluke 35 years ago, and haven't looked back since. I've totally loved my career and how it's evolved through the years as I've gone from a young woman with no children to young children and progressing through the years of the ages of my own kids, and now as a grandmother. I've definitely been able to relate to my families a little bit differently through all the stages of my life.
So most people are familiar with the intensive care unit, but maybe not the NICU, or maybe they've even heard of the PICU. So there's the adult ICU, the intensive care unit, normally just referred to as the ICU, right? And then we have the PICU, the pediatric intensive care unit, and then the NICU, the neonatal intensive care unit. Can you just talk a little bit more about kind of what exactly is the NICU and when parents might find themselves there?
Absolutely. So I think most people have never even heard of a NICU, and when you get a hospital tour, and when those will happen again after COVID, but when you get a hospital tour, usually they say, there's the NICU down that hall, and that's about all you hear. So in general, having a baby that ends up needing intensive care in the NICU sounds very scary for most people, and it truly is a really stressful situation, I think, for all families, regardless of what's going on with their baby. But the NICU in general is just a specialized nursery for those babies that need a little bit more care. And it can be for a full-term baby that maybe is having a little bit of trouble transitioning to life outside of the womb, or a premature infant. And I think most people think of premature babies as the only babies in NICU, but quite frankly, we do get our fair share of full-term babies in there too.
Touched on it a little bit of when parents might find themselves in the NICU, but what are some of the common reasons why you see babies in the NICU? Maybe some of the common reasons for preterm, and then some of the common reasons for full term.
Okay, so full term is the easiest to start with. So the most common reason that we'll see a full term baby in our unit is if they are having a little bit of trouble with their blood sugar, which you'll see in infants that the mom had gestational diabetes, or perhaps she's just diabetic. Oftentimes those babies will have a little bit of trouble transitioning on the outside and maintaining their blood sugar, so they might need a little bit of help with that. Sometimes it's just a little bit of respiratory distress. A common scenario in C-sections is that during a C-section, a newborn may not necessarily get that good, well, they don't get that good squeeze that happens when you go through the vaginal canal. And that squeeze helps to push some of that amniotic fluid that's in the lungs out of the lungs. And so what sometimes can happen is they have what's called a little bit of wet lung. And so they might need a little bit of support. In our unit, that usually looks like something called bubble CPAP. The babies are breathing completely on their own, but that CPAP is just providing a little bit of distending pressure, and it helps drive that fluid out. And so a full-term baby that requires that might just be for hours, a few hours to a few days in the NICU, just depending on the severity of it. Backing up from there a little bit, any baby that's under a 35-week gestation I think this is probably nationwide, will end up in the NICU. Under 35 weeks, babies usually aren't big enough to maintain their heat without a little bit of help. They might need a little bit of assistance with feeding, and you know, sometimes respiratory support is a little bit of an issue, but generally that's that 35, even up to 37 weeks is referred to as late preterm. And those babies are a little bit higher risk for needing some support. But absolutely, a baby that's born at under 35-week gestation will end up in the NICU. A baby that's under 1,800 grams will end up in the NICU. And off the top of my head, I'm thinking that's under 4 pounds. Often those babies will need a little bit of help just with heat for support. Then earlier than that, at the NICU that I work at, I'm at a level 3 NICU. So a regular nursery is referred to as a level 1. Then there's a level 2 NICUs that generally do not keep the youngest of the premature babies. Any infant requiring a lot of respiratory support, certainly any infant requiring any surgery would get transferred to a level 3 NICU. A level 3 NICU will be able to take care of the majority of infants, except those infants that might need complicated cardiac surgeries, have some very difficult, maybe metabolic syndromes, and then they would go to a level 4. A level 4 NICUs are not that common, and they would be in big cities, and there's only going to be like 1 or 2, maybe level 4 NICU in even in the big cities. At the NICU that I work at, we will provide care for infants from 25 weeks gestation and above. If a mom comes in and she's possibly going to deliver her infant between 23 weeks gestation and 25 weeks gestation, because those gestations generally can end up with the babies can have definitely some deficits, could be problems with vision, with hearing, with motor abilities, cognitive abilities. Though that gestation, we will allow the parents to decide, do they want to have full resuscitation efforts done on their baby and see what happens? Do they want to just provide what we call comfort care and just hold their child and provide skin to skin and comfort while that baby passes naturally? Always a difficult situation and a really difficult individualized decision for every family. So we have quite the gamut. We have babies that are in the NICU for a couple of hours. We have babies that are in the NICU for many months. We have babies that are in the NICU that are admitted from home. The most common reason for being admitted from home is for hyperbilirubinemia, jaundice, when they need some phototherapy, oftentimes a little bit of hydration, help with hydration. And then occasionally we'll see a baby back for like maybe a late infection, but in general, our admits from home are babies that maybe aren't eating really well, not gaining weight as good as they should be at home, and having jaundice.
You've mentioned a couple of times that at your hospital in particular, you'll do things one way. What are some of the policies that might change from hospital to hospital where parents might want to ask questions to their OB or maybe call a hospital or ask on their hospital tour to understand maybe what to expect as far as policies go within the NICU unit at the hospital they're delivering at?
Okay, so there's definitely different setups in NICUs. Some NICUs are set up with all private rooms. The hospital I work at, we recently remodeled, built a new hospital and went to an all private room, 35, 40 bed unit. Some NICUs are open bays, and so you just kind of have a space for each baby, but it's like open hallways of or rows of babies. There's definitely advantages and disadvantages to both. I think more NICUs that you'll see are going to the private room situation. In our NICU, parents are allowed to visit 24/7. Even in the midst of COVID, that's not a restriction. Unfortunately, because of COVID going on right now, siblings are not allowed to come in, and other visitors are not allowed to come in, just to try to limit basically the germ pool of who gets to come in. There are some units that never allow siblings to come in. Our unit in particular closes down to children under the age of 18 during the winter months. That's a common occurrence in NICUs because those winter months are your high months for the flu and for RSV, which is a respiratory virus that is a common cold to older children and to adults, but it can be quite devastating to especially a preterm infant that already has some respiratory compromise. So that would be definitely a question to ask. You know, what's the visiting policy for parents? What's the visiting policy for other people? What kind of providers are in the unit? Some units have only nurse practitioners and a neonatologist who's a specialized pediatrician that has extra training in dealing with this population of patient. They may just be in like briefly during the day to oversee care and, you know, write orders. And then it might be that a nurse practitioner is on call the rest of the time. In the unit that I work at, because it is a large unit, we actually have 2 neonatologists on during the day, 2 nurse practitioners on day and night. They work 24-hour shifts, which is a common thing that you'll see with nurse practitioners. And then we have another neonatologist that comes in at night to cover. So lots of coverage, lots of help. And that may or may not be important depending, you know, if you're level 2 nursery that really doesn't have critically ill infants, that's probably fine that you don't have a neonatologist there 24/7. And truly the nurse practitioners, the neonatal nurse practitioners is what they're referred to, are highly trained also, and they're really good at what they do. So.
Great, that's so helpful. What is some of the equipment that you might see in the NICU, just to kind of have an idea of, you know, what to expect in the room? And some of it can be kind of intimidating sometimes, I think, when you walk in there and look at it and maybe see your baby, you know, in the NICU unit. But what are some of those things that are just kind of standard, or, you know, what can you expect to see while you're visiting?
So the first thing you'll notice when you walk into a NICU is an incubator, which in general, it's referred to as an isolette now. But most people think of them as incubators. So that's an enclosed plastic house crib that is the infant's bed. And there's heat that's provided in there that's controlled. I would say most modern units now have the same kind of equipment, whereas the lid, the top of that incubator raises up and then becomes an open crib for the infant, or if procedures are being done and actually radiant heat comes from above onto the baby, and that's controlled with a temperature sensor that's taped to their abdomen, so to control the amount of heat that comes in and out. Usually it's only the younger babies, those babies that are, I wish I knew my pounds as opposed to just, I'm so used to metric now. So like under 3 pounds that would need the enclosed isolette. Another example would be an infant that is under needing phototherapy, and they're obviously going to be laying there just with a diaper on and the rest of their skin exposed, so that they would be in the enclosed isolette to maintain their heat. So there's the isolette. Some units will transition from an isolette to like just a regular bassinet as the babies get older. I think it just kind of depends on how the unit is set up. Babies will be on a monitor. You'll see a monitor mounted on the wall or next to the isolette, and that's attached to the baby with electrodes. There'll be 3 electrodes, 2 on the chest and 1 on the lower abdomen. And that gives a continuous readout of heart rate and respiratory rate for the infant. So even if someone isn't in the room, that baby is constantly being monitored. The other thing that the infants will have is a pulse ox on. Pulse ox will measure the oxygen saturation in the blood. And that's usually a tape-like probe that's taped around a hand or a foot, and so that we can constantly see what the oxygen level is of the baby. Beyond that, there'll be different levels of respiratory equipment that will be seen. The simplest of which is just a simple nasal cannula like you would see on an adult. That's usually for babies, like premature babies that are gradually getting better and they progress to that. Often in Colorado, where we're at a high altitude, we will frequently discharge babies home on oxygen, and they may be on oxygen from weeks to months, depending on the severity of how premature they were, how immature their lungs were. Not as common in low altitudes, because generally the amount of oxygen we're sending these babies home is just to compensate for our high altitude. Progressing up from that would be bubble CPAP. There's different, or CPAP, we use a bubbling machine, but there's different modes of giving CPAP. CPAP has become quite commonplace because it's not invasive. It just involves a bigger prong that fills the nostrils, but it provides a lot of distending pressure for the babies to help open up their lungs. I like to tell parents it's like when you have a balloon that's completely deflated. It's very hard to blow up, but if you have a balloon that's partially inflated, it's much easier just to finish inflating the balloon. So that's what CPAP does for the lungs. It provides that distending pressure so that the babies they do all the breathing on their own, but it just assists, that makes it a little bit easier. When we have a premature infant, generally we'll keep them on CPAP up till about 32 weeks gestation. If they've progressed to that, because CPAP in and of itself, the bubbling that we use provides a mechanism that actually helps promote lung growth. So we can also provide CPAP through a ventilator that provides some actual breath. So you would have like a inhalation, an extra burst of air that would go to the babies. Sometimes the younger babies who aren't quite strong enough to do all their breathing on their own will need that. Also, it's a nice mode of ventilation because it's non-invasive. And then the most invasive is actually being intubated with a breathing tube on a ventilator. There's different types of ventilators. That would be for your very young premature babies, or a very ill older child, older baby, more term infant, maybe that has pneumonia, ventilators are super important, but they also do damage to the lungs. So the goal is always to get a baby off of the ventilator as quickly as you can and get them to a CPAP mode. You'll also see IV pumps, feeding pumps. So, kind of a myriad. It could be as simple as a crib and an IV pole on the monitor, or there could be a lot of equipment in the room, depending. One of the biggest questions that parents have about being in the NICU is about feeding their babies. Often, even with our youngest, 23, 24, 25 weekers, the once they get over the whole respiratory journey portion of their journey, the feeding element is the hardest one for those babies to put all those pieces together. One of the things that we cannot stress enough is the importance of a mother's own breast milk. So should somebody that's watching this video, you end up with a baby in the NICU, as hard as it is, that is, we call it liquid gold. There's nothing better that we can provide for your baby than your own breast milk. Ironically enough, insurance companies do not pay for nutrition for infants. So, and donor breast milk from certified milk banks is very expensive. It's $4 to $4.50 an ounce. It's something that is very, very essential in order to bridge the gap for those couple days when mom's just starting to pump and establish their milk, or in situations where we have a very premature baby and for some reason the mother's is not able to provide milk, whether physically she's not there. We've seen this with surrogate situations, or perhaps she just is not able to produce enough milk on her own. So that's should you end up in that situation, I would say that would be the number one priority of any mother, besides getting into that NICU and doing as much skin to skin as you can based on your baby's condition, is getting yourself on a really good schedule to establish a really good pumping regime, because that milk is so, so important for your baby's growth. The benefits are far outweigh formula. We actually find formula to be very dangerous to use in premature babies because it can be pretty damaging to their guts. But it's also quite a bit better than donor breast milk, because donor breast milk has been pasteurized, and certain good qualities in it, components in it, have been destroyed in that process. So there's nothing like mom's own milk for that. In general, babies learn how to start coordinating the three components of feeding, which is sucking, swallowing, and remembering to breathe, at around 34 weeks gestation. So if you have a baby that comes into the NICU that's between 34 and 35 weeks, they're not often, they're just at that age where they're really starting to be neurologically able to put that together. There are some in that gestation that are fine. They, can take everything by a combination of bottle and breast, but oftentimes they'll need a little bit of help, and that will come in the way of putting a feeding tube into their nose, goes into their nose, down into their stomach. It's taped to their side of the face. It just stays in. We switch it from one side of one nostril to the other every week. And then the nice thing about that is it leaves the baby's mouth free to nuzzle at the breast, practice with breastfeeding, take bottles, and then what they're not able to do goes in that feeding tube. Prior to 34 weeks gestation, because babies don't have the neurological ability yet to coordinate feeding, then all the feedings, once they progress off of IV fluid and onto full breast milk feedings, then it's all given through a feeding tube. They're referred to as gavage feedings, like garage with a V. Something else that's interesting that people are often surprised by is that a premature infant will not grow sufficiently on just plain breast milk. And there are products out there that are referred to as human milk fortifiers, and we add that to breast milk. They're made by formula companies, and it boosts the calorie, protein, minerals of the milk in order to provide some substantial growth. In the early years of my career, we didn't have that. We only had breast milk, and we had a lot of babies that had rickets, which is brittle bones. They equate growth prior to going home, getting them up, you know, doing great on their growth curve, to long-term developmental outcomes, super important for the brain to get enough protein. So nutrition is so important in the NICU.
What advice do you have for moms to help them establish their milk supply in the early hours, early days? I know that first hour can make all the difference.
Exactly. And that's our goal, is that moms will be, you know, start pumping within the first 1 to 2 hours. And that's really even moms that have had a C-section, maybe are on magnesium for high blood pressure, for preeclampsia. You know, unless they are critically ill, then pumping, you know, getting started pumping right away. Hand expression is super important in addition to pumping. Your hospital should have a hospital grade pump to use. That's something a lot of hospitals then will rent that. And that's a hospital grade pump runs between $1,500 and $2,000. It's a very expensive pump, nothing that you would want to purchase on your own. But when you're relying on a pump solely to establish and maintain your milk supply, that's super important. For the average person that's able to, you know, breastfeed, and it's not necessary. So truly, I would recommend, I think there are a lot of apps out there, and I would download an app on your phone, set up a schedule, and just get it going. You need to pump 8 to 10 times a day. It doesn't have to be like every 3 hours, you know, exactly. You could go 3.5, and then you could make it up with 2.5. What I see most often is mom's milk will start to come in and they get really excited, you know, day 5 or 6, they're pumping more. And then they're like, oh, I'm so exhausted. And they start stretching out at night. And first it's maybe 4 hours, and then it's 5 hours, and then it's 6 hours. And then all of a sudden their milk is like really slowing down. And it's, you know, it's such a hard ask, because I know how difficult that is. You're supposed to be getting up in the middle of the night with your baby, and instead you're getting up to a machine. But it's so important. And if you want to maintain long-term success, you know, and you have it in a goal that you want to be able to breastfeed your baby, it's really important to establish that milk early on. That being said, it is not a realistic goal that you will take your baby home from the NICU exclusively breastfeeding. That's something that parents will work up to, but breastfeeding is actually harder to do for an infant than a bottle. They have to work a little bit harder at it. There's a lovely aid called a nipple shield that looks like a clear witch's hat. It's nice because it gives the infants something firm to latch onto, because they're not strong enough. They don't have the muscle strength, and oftentimes they don't even have a big enough mouth to like really get that nipple in their mouth and move it back to the back of their mouth and maintain that latch. They take a rest and then they lose it, and they have to reestablish that. Whereas by using the nipple shield, and so we use that quite frequently to help establish breastfeeding on the premature babies. Not every baby needs it. It's depends on mom's anatomy oftentimes, but it's a nice aid. And then when a baby gets discharged, in the ideal world, they would be probably breastfeeding about half of their feedings, and then getting breast milk that's fortified with a little bit of extra calories in it the other half. And then their pediatrician would watch their growth, you know, on the outside during their appointments, and decide when they can stop getting that supplementation. And then, you know, hopefully the ideal would be just to transition over to exclusive breastfeeding. But
Great. So renting that hospital grade pump, like you mentioned, getting in those 8 to 10 sessions, 8 to 10 pumping sessions, and not, you know, 8 to 10 all stacked together during the day, but really stretching them out around that 24 hours, every 3 to 4 hours, 8 to 10 sessions during the day, and then maybe using the nipple shield to help baby get that latch and establish that early on, right?
And so I get one of the things I would ask, if you were on a tour, or you were calling a hospital and seeing, you know, what their policies were, is how do they feel about skin to skin care? We do, as soon as our smallest babies are stable enough, which could be a matter of a few days. And I'm talking about our little, 1-pound babies that are still on ventilators. We get them skin to skin with mom because we know how important that is for both the baby and the mom. Stabilizes the baby's vital signs, helps with their growth, brain growth, numerous benefits for the mom with their milk coming in, for oxytocin release, for helping to prevent depression, postpartum depression. Dads are also encouraged to do skin to skin in our unit. So we actually in our unit have something called family integrated care, where we really want our parents to take ownership of their babies and be involved in every aspect of their care that they want to be involved in. When you do have a baby in the NICU, especially a younger baby, and you're just petrified, a lot is taken away from you. There's a lot that you want to be able to do for your baby, and short of helping to take temperatures and do diaper changes and skin to skin, there's not a whole lot more that you can do early on. And so during especially a long journey that's several months in the NICU, we really want those our families to feel like this is their baby and they are part of the team. They're just not visitors. And when they go home, they are experts on their babies, and really feel comfortable with that. So I think that's an important question to ask, how much do you like family involvement?
That makes sense. Now, I know we've touched on it a little bit already in this call, but just the emotional stress that can come from having a baby in the NICU and how difficult that can sometimes be. What are some of the types of support that are out there for NICU parents, or, maybe what advice do you have for them to help find support in their area or at their local hospital even?
I know there are support groups out there that some NICUs offer, and we kind of have found in our NICU that always felt flat. People, when they are in the hospital, they want to be with their baby. They don't want to be in another room with a bunch of parents. And so what we have found to be really helpful is we have a dedicated Facebook support for our NICU families. It's moderated by 2 nurses, so other nurses, the rest of the staff are not seeing these posts. And it's lovely because we have parents that have been were in the NICU 10 or more years ago that are on there supporting parents through their journey now. People can ask questions, people can voice concerns, and that's a great support. We have caseworkers, social workers that are there for support. And truly, I think that if you have a support circle within your extended family or your friends, asking people to make meals for you, easy meals that you can take to the hospital, a dinner that you can pop in when you get home. In general, families do not, unless it's a really short stay, or perhaps the end of a stay when a mom wants to just stay overnight and work on breastfeeding through the night. Most families will go home at night. They just kind of find out their routine that works for them. And there's so many factors. Do you have a car? Do you have younger children at home that need to be watched so that you can go to the hospital and spend quality time? So you just, can you reach out to friends and have friends watch your younger or your older children? Excuse me. So I guess the bottom line is not being afraid to reach out and ask for help. Being in the NICU is extremely stressful and nobody gets it. Your friends and your family will really not understand the level of stress that you're under. And oftentimes I'll hear parents say, they're like, well, he's 5 pounds now, why isn't he home? Or he's 6 pounds now, well, why isn't he home? And they just, family really have a hard time understanding what the whole journey about, and just truly how stressful it is to, to leave the hospital every night or every day when you go to visit and not be able to take your baby home with you. Also, that being said, should you have an infant in the NICU that's there for a long time, give yourself permission to not have to visit every single day. Sometimes you just need a day to like take care of yourself, or go do something with your spouse, your support person, so that you can get a little bit of distance. I've also heard from parents that PTSD, post-traumatic stress disorder, is really common post-NICU. Hearing beeps and sirens and whatever, many of the moms that I've kept in contact after discharge have sought out some counseling. Also, some have even done it while they're still in the unit. I'm talking about people that are there for 2-3 months. And that really helps, because you just have to process this. It's a huge loss. This is not your expected journey. There are definitely some wonderful things that happen in the NICU. I think also when you have one of those late preterm babies that happens to be in the NICU and you're so disappointed, and so often I'll hear, oh my gosh, we learned so much while we were here, and that's kind of the silver lining. But being in the hospital for 3-4 months with your baby, that's a long journey. It gets very tiring, and it's a lot to process. And when you don't really have people on the outside that can really relate to what you're going through, you might just need a little bit of extra help. So,
Any words of encouragement for anyone who's watching that may be going through this right now?
I would say make sure to take care of yourself. Acknowledge that this is hard. This, it's a grieving process that you should allow yourself to go through, that you've lost your picture of what your perfect birth experience was going to look like. And then just, kind of do the best you can. It's definitely a marathon and not a sprint in the NICU. There's good days and there's bad days. There's steps forward and there's steps back. And, you'll get through it, but some people's journeys are definitely harder than others.
Do you have any advice for the mom who might be watching who's still pregnant now and is maybe worried about what could happen during birth or during her labor, or just any words of advice or encouragement to maybe help ease any fears going into
Gotcha.
birth?
Well, for those people that are watching this that are now terrified, 10% of all babies end up in the NICU. It's a very small percent of babies, and oftentimes those are for very brief visits. I would say, in a unit of 40 beds that I work in, the majority of babies are that maybe 32 to 34, 35 weeks gestation that really just need a little bit of help getting stronger and growing and learning how to eat. And as stressful as that all seems, they will be fine and they will thrive, and you will get so much support. And you just have to, it's not really as scary as you think it is.
I think that's helpful. Thank you so much for joining and sitting down and chatting and helping to maybe dispel some of the fears of a unit that's otherwise really unknown to most of us. Like you said, you don't really get a chance to go in there. It's kind of that's the NICU on the hospital tour for those who are able to take them, and you don't really learn a whole lot until you're thrust into it. I think sometimes that fear of the unknown can add to the anxiety of it all. So thank you for sitting down and sharing. I just appreciate you taking the time and being here. For anyone who's watching, I'll post some links down below where you can maybe find some additional information or support, and then we'll see you next week for another episode.